So I'll get started. Thank you, everyone, for joining. Thanks for having me at the Methods Speaker Series. My name is Wojtek Wiercioch. I'm from McMaster University in Hamilton, Canada, at the Department of Health Research Methods, Evidence and Impact. And I work as a postdoctoral fellow and research methodologist at the McMaster University Gray Center. And for today's webinar, I will cover innovations in methods and evaluation of guideline development. And the session is meant to be an overview of current developments and latest developments in the production of practice guidelines. And after the session, there should be time for questions, as we mentioned. And throughout the presentation, I'll stop at a few key points to see if there's any questions or clarifications needed from the group. So to start, in terms of disclosures, I don't have any financial conflicts of interest related to any of the work that will be presented. And I am a member of the Grade Working Group, and I'll pull some examples from work by the Grade Working Group or members of the Grade Working Group throughout the presentation. And our objectives for today are to cover methods and new approaches in guideline development. And I'd like to highlight in this presentation methods for rapid guidelines, living guidelines, recommendations, making recommendations when there's low or very low quality evidence, and then get into evaluation of guideline development, including tools available for evaluating guideline methods and processes and reporting of guidelines, as well as the new panel view instrument that can be used to evaluate the guideline process. So methods and processes for developing guidelines have been outlined, formalized, and evolved over time. They've been described in various methods publications, guidelines for producing guidelines, and in guideline manuals from guideline developers, such as those highlighted here. And advancements in methods and formal frameworks have aimed at making recommendations and guidelines that would be considered rigorous and trustworthy, as well as useful to care providers and decision makers to improve patient care. And something we see going around on Twitter these days is the how it started and how it's going. So in terms of guidelines and methods for guideline development, in 1990, the Institute of Medicine defined guidelines as simply as systematically developed statements to assist practitioner and patient decisions about appropriate health care for specific clinical circumstances. In 2011, this definition was updated to statements that include recommendations, specifically outlined now, intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternate care options. So you see those details introduced about recommendations relying on systematic reviews and formal assessment of benefits and harms. And with these definitions, we've moved from simple classification systems of the quality or category of evidence based on study type, for example, as you can see here, to formal frameworks of assessing the certainty of the body of evidence, such as the GRADE approach, as well as evidence to decision frameworks, such as the GRADE-EC framework, highlighting specific criteria to consider for formulating recommendations. In guideline development, there are essentially two main steps or phases, which is assessing the evidence transparently, gathering in a systematic review research evidence to get an estimate of effects of interventions, assessing our confidence or quality of the evidence, assessing the single studies for risk of bias, and having a body of evidence with the quality assessed to inform a recommendation. And then in the subsequent step, we develop structured healthcare recommendations. So using an evidence decision framework, we consider the criteria and factors that would influence recommendation, and we seek to end up with clearly developed and formulated recommendation statements. This over time has led to the development of guideline standards, such as those from the Guidelines International Network, shown here, and those from the Institute or National Academy of Medicine, as it's now known, including specific standards around how the evidence should be synthesized, how scope should be determined, how conflicts of interest should be managed, etc. And that has led us to having more rigorous methods for developing guidelines and standards that we should adhere to when we develop guidelines. In terms of continuing then things for the advancement and progress in guideline development and methods, one piece of work I'd like to highlight is that of the development of the GIN, what is now known as the Jim McMaster Guideline Development Checklist, which was published in 2014 in the CMAJ. And the checklist outlined 18 domains for guideline development, considering each of the steps that should be completed or considered by guideline developers in completing a guideline from start to finish. So starting from organizing the project, determining budget, all the way up to reporting and dissemination and implementation considerations for the guideline. And in this checklist, we have specific items for guideline developers to consider to complete each of the steps. And the overall guideline process is highlighted in a figure that was included with the development of the checklist. And the guideline development process involves multidisciplinary groups working on specific steps, including prioritization, evidence synthesis, developing recommendations, and reporting. And each of the steps requires specialized knowledge and participation from these group members, including an expert panel, guideline methodologist, a systematic review team. And details about the methods and decisions for the development of the guideline are then reported in either guideline publication, peer-reviewed publication, or methods manuals or meeting minutes. And in terms of advancements in guideline development methods and using this approach, using the guideline development checklist to guide a project, I would like to present one example of a project that we have been working on for the last few years, a very large guideline development project with the American Society of Hematology in partnership with the McMaster University Grade Center, where we set out to develop 10 guidelines related to BTE management with a range of 10 to 30 questions addressed in each of the guidelines for a total of over 250 recommendations. And currently, 8 of the 10 guidelines are published, with the 9th and 10th guidelines coming soon. The most recent guideline published was the BTE treatment guideline. And we have also followed up with a methodology publication to outline how we use the guideline checklist and those steps in the checklist to complete the project, and new approaches we've implemented and innovations we implemented as part of the guideline development process to complete this large project. And I'd like to highlight a few of those methodological approaches here, just as an example for those who are interested. And in the publication, we actually provide as a supplement all the tools, questionnaires, for example, survey tools that we use for this project that others who are working on guidelines currently can use for their guideline projects with their organizations or their guideline panels. So just to highlight some of these, we used an overarching organizational approach where we had a hierarchy of guideline panel chairs and methodologists and systematic review team leads and systematic review team members that guided the overall process. So hitting on that organization and group membership piece in the process figure of their checklist, we were able to coordinate the work of the 10 guidelines in parallel to take place and achieve consistency in our methods. And throughout the process, we had an explicit COI policy that the American Society of Hematology developed in consultation with the guideline methodologist working on the project and the principal investigators working on the project that ensured management of relevant conflicts of interest while allowing participation of those who were recused in the guideline development process, in that they were able to discuss evidence and contribute to the process even though they had specific conflicts, but they were recused from making any judgments or influencing or commenting on the final recommendation. And that was one innovation we implemented to manage conflict of interest across this large number of guidelines and guideline panelists. For our evidence synthesis, for each of the guideline questions, we conducted or updated existing systematic reviews for intervention effects, including also systematic reviews for additional evidence, including patients' values and preferences, costs and resource use of interventions, feasibility, acceptability, the additional domains in the evidence decision framework that would inform recommendations. And this was done for each of the questions using standardized methods and templates following Cochrane methodology to conduct the systematic reviews. In terms of developing recommendations, we implemented online pre-voting and review by panel members to provide their input on the summary of the research evidence, as well as on draft recommendations in some cases, where the preliminary work prior to final panel meetings was able to be held online with preparatory teleconferences and online voting software to be able to better organize the panel discussion at the meeting. And finally, for dissemination and implementation, Ash, together with the team, developed a number of implementation tools, including a mobile app, patient versions, online interactive summary of findings tables, and teaching sites, all as part of the guideline output or products that were included. So this highlights a few of the new approaches and innovations we use following that guideline development checklist and each of those 18 steps of guideline development. So here's where I'll pause for any questions as I get into the next topics of the webinar. Yep, so do the guideline developers use similar process in different parts of the world? So that's a very good question. In general, the guideline standards that are developed by the Guideline International Network, which is an international network of guideline developing organizations, put out the standards that are meant to be applicable to guidelines developed all over the world on different clinical topics, and not only, for example, clinical practice guidelines, but they would also apply to health policy guidelines. Likewise with the National Academy of Medicine. So the processes used in different parts of the world may differ, but what they should do is seek to achieve those standards. For example, using existing systematic reviews or updating systematic reviews, basing recommendations on the best available research evidence, using conflict of interest management policies, etc. One thing that may differ, or one aspect I want to touch upon, which isn't included in the presentation, is adaptation of guidelines, and one method that we call adultment of guidelines, which we also published on a few years ago about using existing systematic reviews and evidence syntheses, using evidence to decision frameworks of guidelines that have been produced to adapt them to the local setting. So the process there differs a little bit from a de novo guideline, where you're starting from scratch, conducting systematic reviews, updating, to a point where you're adapting the guideline and its recommendations by starting with an evidence synthesis and then working through those ETD criteria, where you would come up with a recommendation that's contextualized for the local setting. So that's one way that, processes may differ in different parts of the world. In terms of guideline development, it's a resource-intensive activity. So, of course, low resource settings in terms of both skills, methodological skills, and in terms of funding, may use adaptation methods, such as the one I mentioned, to produce guidelines. Thanks for the follow-up question. So the follow-up question I'll leave for the end, and we can discuss that in terms of why is there varying use of systematic reviews, because that will also touch upon evaluating the guideline process.
Okay, great, thank you.
So in terms of the next components I wanted to address in the webinar are current needs and guideline development. So what is new? What are the current both trends and needs in developing guidelines to guide practice, policy, and decision making? And I've organized these into three topics. One is responding to urgent issues and needs. The second is maintaining guidelines and up-to-date recommendations, and then finally making recommendations with insufficient evidence or very low or low quality evidence. And if you think back to what might tie these topics together is, of course, the current COVID-19 pandemic that we're experiencing that really brought these issues to light in terms of making recommendations in each of these situations. And I'll use a couple examples from the COVID-19 pandemic about guidelines that were addressing these issues. So in terms of responding to urgent issues and needs, for this we have methodology around rapid guidelines. So the goal here is getting recommendations to our target users, clinicians, patients, policymakers, faster than what you consider the traditional or regular process, and as the need arises, as there's an urgent need for recommendations. And this is really an aspect of time available and time given, and also specific shortcuts you might be able to take. So thinking about the guideline development checklist, each of those steps, where could we cut down the time taken to produce a guideline rapidly? And of course, this becomes an issue of human resources again, because you might be able to complete all of those steps, but in a rapid fashion because you have multiple people working on large teams that are able to divide up the workload. So the aspect of rapid really has to do with time and also potentially some shortcuts you might be able to use in the process to cut down on the time to produce a guideline and recommendations. So there are going to be some specific considerations for conducting rapid guidelines. Again, referring back to the checklist across those 18 domains of guideline development. And I highlight here a publication from 2018 about those considerations and an extension of the guideline development checklist for formulating and producing rapid recommendations. And in terms of the methodological and process considerations, there are a few specific areas where we need to consider for producing rapid guidelines. Highlighting issues around organization, priority setting, and guideline group membership. We have to consider the time available and the time frame to work in. For example, is there need for emergency guidance? Is it something that needs to be produced within a 1 to 2 week time frame or a 1 month time frame, which I'll touch upon in one example on the next slide. In terms of the panel structure, again, we need to convene a panel of experts to formulate the recommendations and consider how will the panel operate. So in terms of meeting structure, of course, this applies less so now that we've moved into a virtual world, conducting panel meetings virtually instead of in person, for example. It also includes maintaining a specific policy and a rapid process for obtaining conflict of interest disclosures and managing them. So in this example, doing a process, a guideline process rapidly doesn't negate the need for managing conflicts of interest. Again, that's something that we want to maintain and consider. In terms of the questions, outcomes, and evidence synthesis, we want to limit the number of questions because that has to do with the time available and feasibility. And we may rely on existing information about what important and critical outcomes are, for example, looking at core outcome sets, or implementing a process that is more rapid where the panel chairs may make decisions and panel input will be sought for agreement versus what may be a typical brainstorming phase with the whole panel prioritization phase and final selection of health outcomes to consider for which to conduct systematic reviews. In terms of conducting systematic reviews, we may rely on existing systematic reviews and update those to save time on the evidence synthesis step of guideline development. And there's specific methods and a presentation from Dr. Adrian Stevens from the TI Methods series that covered rapid systematic reviews. And For steps such as obtaining additional information about cost, acceptability, feasibility, where there may not be time to conduct a full systematic review or there isn't an existing systematic review, we may use input from the panel to suggest specific studies, for example, and obtain information on these additional factors. Again, one area where we could cut down potentially on time. In terms of developing recommendation, we could use a process of pre-voting as well ahead of any panel discussions and consensus meetings so that the whole panel has a chance to review the research evidence, propose some judgments and potentially draft recommendations, and have that information available and that preliminary and preparatory work in order to have the consensus meetings be more efficient when it comes to making the final recommendation. And of course, we would want to finalize and agree on wording of recommendations during meeting to not draw out the process and to have the panel agree on what might a final recommendation look like while they complete the process and as they are in the room, essentially, completing the recommendation. And finally, in terms of reporting, dissemination, implementation, rapid guidelines may look to expedite internal and peer review, make arrangements in advance with journals, with the organization to complete internal review. This may also include informing the audience in advance that the guidelines will become available. So when the process starts, putting out a news alert, for example, to relevant and key members of the target audience. So those are some considerations for the methods that may be applied to producing guidelines more rapidly. And of course, these are covered in more detail in the publication example. And going back to time frames, one recent publication I want to highlight as well from colleagues from the GRADE working group is using GRADE in situations of emergencies and urgencies, and producing recommendations in a rapid time frame, where the group had separated out specific types of responses according to the time frame available. So there are those emergency or ultra short time responses that are within hours, urgent responses that would occur within 1 to 2 weeks, rapid responses that would occur within 3 months, and then the routine responses that may take up the regular time and take more than 3 months. And some examples from the from research questions related to the COVID pandemic are given for each of these time frames. So that's one way to consider in terms of the time available and the specific research question, what methods in the guideline development should be implemented and planned by the group depending on how much time they have. So for example, going back to that ultra short time frame, you may do a rapid evaluation of evidence from other diseases, other populations, what's available there, not having time to do a full systematic review, for example. This is a useful framework to work within for considering producing rapid guidelines. So the other aspect and current need in guideline development is that for maintaining guidelines and up-to-date recommendations. And here is where the concept of living guidelines comes into play and is fairly recent development over the past few years for producing guidelines and implementing a guideline process to update recommendations when new evidence becomes available. And here I've highlighted one publication that gives some information and considerations for living guideline recommendations from the Cochrane Living Evidence Network. So for producing living guidelines, the methodological considerations we need to take into consideration is when to use guidelines. So for a question, thinking about the question and recommendations that are to be formulated, this needs to be a priority for decision making at this time. We should expect that the recommendations may change with new evidence. That's the main consideration, is we need to make a recommendation now, but we expect that there is new evidence anticipated. There may be research in progress that we know of, but decision makers need a recommendation now, and the living guideline approach will maintain that recommendation and assess any changes as new evidence becomes available. And for this, we can adapt the process, again, thinking back to the steps of guideline development in the guideline development checklist. For prioritizing questions, we want to identify questions that are suitable for living recommendations. For conducting the evidence synthesis, we would need a living systematic review where we monitor for new evidence, we inform the guideline panel of new evidence, and assess the new evidence as it becomes available. For the living guideline panel, we need to maintain membership of the panel, the appropriate balance of expertise, considering that a living guideline will now take a longer specific period of time for which we need to maintain the panel. And as well, we need to maintain the conflict of interest management policy as membership changes, for example, as conflicts potentially change over time. We then need to consider how we will reassess the recommendation and have explicit criteria. This, for just as one example, maybe the change in quality of evidence for the health outcomes that are considered, and work with the panel to reassess and update the recommendation as needed. And for reporting, we need a living peer review and publication process, which would include making arrangements with the publication journal, making arrangements for peer review and internal review for the living process as the recommendation and evidence are updated in each iteration of the living guidelines. We would need to implement the peer review process at those stages as well. So these are the main considerations in adapting the process to producing living guidelines. And I'll highlight the living guidelines example that I had mentioned before, which is also from the American Society of Hematology on guidelines on use of anticoagulation in patients with COVID-19, which were released in late September and are available online now as draft recommendations. And the panel prioritized 2 questions, and the guideline here includes aspects of both the rapid guideline development approach and the living guideline development approach. So in terms of getting the recommendations issued quickly, the panel prioritized 2 specific key questions on use of anticoagulation in critically ill and acutely ill patients with COVID-19. The guideline recommendations were released online for a public comment period and are available, made available prior to the peer-reviewed publication, including the full evidence synthesis and summary of the findings from the living systematic reviews. And one point to highlight here, for example, in the review for critically ill patients, there was just one observational study that was relevant to the question that was identified, upon which the panel made the recommendation, along with other considerations, which were reported transparently in the evidence to decision framework, where the panel considered the benefits and harms based on the systematic reviews, patients' values and preferences, resource use, health equity, acceptability, feasibility, etc. So even with the sparse evidence, the panel is able to work through the framework, reports transparently each of their considerations and specific judgments that they made to come up with the recommendation. So as I mentioned, this included both the rapid and living aspects. In terms of rapid aspects, it included relying on existing information about importance of VT-related outcomes, which were taken from the existing 10 VT guidelines that I mentioned in the first example. It included relying on existing systematic reviews about costs of anticoagulation and patients' values and preferences. In terms of the public comment period peer review, it included an announcement about the guidelines being in progress, a public comment period being implemented, and communication with the journal for peer review and submission of the guideline report. And finally, the draft recommendations and the supporting evidence decision frameworks were released online during the public comment period to rapidly disseminate the draft recommendations. And in terms of the living components, living systematic reviews were conducted for baseline risk information and anticoagulation effects, which will be updated monthly now for the living phase of the guideline for the next year. And in terms of the living component with respect to the guideline panel, we will maintain a standing living guideline panel and a process for monitoring and reassessing the recommendation as new evidence becomes available. So I'll pause for any questions and comments there on the living approach for guideline development.
So, Wojtek, I was going to ask, so this whole living guideline process is very new, right? And I was wondering if there's any case studies that have, including your experience yourself with how easy is it to have, the panel members, engaged throughout the whole process and be retained?
That's a great question. So in terms of the methods, they have been developed over the last couple of years, but as you mentioned, now we're starting to see, especially this year, the living guideline approach being implemented. So in terms of maintaining panel membership and any difficulties, I'm not aware of any case studies, but that is an aspect that we plan to evaluate during our COVID-19 guideline project. That's one of the issues we highlighted and anticipated initially is how to maintain the guideline panel, how to maintain appropriate level of engagement, particularly during those times when the evidence is being updated and work is being done in the background. And of course, the requirement and onus of on the panel to stay involved and whether they'll be able to continue. So I'm not aware of any current case studies. I'm not sure if others maybe are. Feel free to suggest them in the chat. But that is an aspect we want to evaluate.
Great. And as with regards to the panel itself, do you especially think about the representation of different types of panel members in the group, not just patients, but clinicians and methodologists and statisticians, that type of thing?
Yeah, so for that aspect, in terms of the living guideline, it wouldn't vary much from the typical guideline process in that you want to maintain that representation. So on this guideline, we did have 3 patient representatives. We did have guideline methodologists and a large systematic review team involved, non-voting members of the guideline group. And the representation in terms of clinicians on the panel was also considered by the guideline panel chairs and ASH as an organization to involve the various experts needed to address this question of anticoagulation and COVID. And one thing we'll need to consider as we go through the living process is to maintain that composition. For example, if we have 3 patient representatives that if they're unable to continue, whether we would include new patient representatives on the panel, or if there's a specific clinical topic area for which a panel member would need to drop out, that we replace that. So it's a consideration taken into place at the beginning. And for this guideline, we had quite a large panel with over 30 members, I believe. I'd have to go back to get the exact number, to ensure that we had that representation. But definitely that's something we'll need to monitor as the living guideline progresses.
Great, thank you.
Very welcome. So with that, I'll move on to the third component, an issue we are discussing that has also gained attention with, again, with the pandemic, formulating recommendations based on insufficient evidence. So we've seen this coming to light, but it's also an issue that has been experienced by guideline panels on other topics and in regular or traditional guideline processes, if we call them that for some specific questions that the panel and clinicians, patients, and the different stakeholders prioritize, there is not much evidence available or any direct evidence available. And the question arises, should the panel make a recommendation in that case, or should they not make a recommendation? So with this, I'll just go back. So with this, the question is, should we make recommendations? And the argument here is that we should, given that guideline users, decision makers want guidance. These questions have been prioritized for a reason, because decision makers want to be guided with specific recommendations. And by convening a panel, reviewing all available evidence, and realizing that there really isn't much evidence, or evidence is lacking, or it's low or very low quality evidence, it's still a potential missed opportunity, because the panel is in the best scenario of actually making a recommendation as compared to individual practitioners who still have that question. And I've highlighted also a recent commentary by Drs. Newman and Schoenemann about, again, making recommendations when evidence is considered insufficient. And we do have methods and approaches for dealing with this scenario, in that we want to collect all available evidence, so direct evidence of all types, not only randomized controlled trials, but also observational studies, looking at indirect evidence, other relevant populations, interventions or comparators from which we can draw and make inferences about intervention effects, for example. And we have the expert panel from who we could formally and systematically collect expert evidence or observation, which is different from simply expert opinion, in that we could survey panels on their observations and experiences in clinical practice. And we've commented on that in this BMJ publication about distinguishing opinion from evidence, and describe an approach where we could collect evidence from panel members when published evidence isn't available. And that, of course, includes looking at data registries, unpublished evidence that the panel may be aware of, but that isn't identified in systematic reviews of your typical databases. And in terms of formulating recommendations, we can again use an evidence decision framework to transparently make judgments and outline all the considerations made by a panel when that evidence was considered very low quality or lacking, and still come up with a specific recommendation. Circles back to the opportunity for living recommendations if new evidence is expected to be published. And one example I'll pull from is from the American Society of Hematology 2018 VT guidelines on treatment of pediatric venous thromboembolism, where the panel, for one of their questions, only had indirect data from one adult study, this for being a question about pediatric patients, and for which we actually surveyed the panel based on their experience from their clinical practice on progression of the disease and specific outcomes that patients, pediatric patients in their practice experience. So for example, the panel members were able to recall and collect the information about specific outcomes they saw in practice and relay that back to the whole panel. And this example we described in the, in this approach we described in that publication. So this highlights how we can make recommendations when there's very little or very low quality certainty in the evidence, or it's lacking. And again, the COVID pandemic brought this into light, because we are in that situation where we have a novel disease and we need to make recommendations and decisions about treatment, diagnosis, etc., for which we are yet to have direct evidence. So in the interest of time, I won't pause for questions now. I'll cover this last aspect of the presentation, and that is moving to evaluation of guideline development. So regardless of the process, whether it's regular or your typical guideline process, whether it's rapid or living, we need to make sure that we are doing it well and issuing recommendations that are trustworthy. We need to ensure that there's rigor and transparency in the methods, process, and reporting of the guidelines. And we want to identify strengths and weaknesses in methods and the process to inform quality improvement of guideline development. An example that was mentioned in terms of evaluating the guideline panel composition is falling into this topic of overall evaluation of guideline development. So we know that problems may arise during the guideline development process. For example, a guideline group may collect disclosures of interest, but conflict of interest still make their way into the panel discussion during formulation of recommendations because the conflict of interest wasn't managed well. It may have been reported and disclosed, but it still made it into the process and influenced recommendations. The process may be prone to influence by individuals with strong opinions. If the panel chairs, for example, are not able to appropriately manage the discussion and allow equal input from all panel members. And we have available reporting and appraisal tools for guideline development, such as the right statement. So the right statement is a tool for specific details to include in a guideline report. So it's a reporting tool to make sure that the guideline publication covers the relevant aspects that readers should know about in terms of the process and methods that were employed. And we have available the Agree-To instrument, which is a reporting checklist as well to evaluate guideline reports and the guideline development steps that were reported to make an appraisal of the credibility of a guideline. However, what is reported may not be complete in those reports and may also not reflect the process given how the panel may interact, the panel may complete the process, how the evidence synthesis was done, etc. So some aspects of the guideline development process become a black box for which we rely on the reporting of the guideline authors and need to evaluate whether the steps were done or not. So current instruments assessing the trustworthiness of practice guidelines rely on the author's report or from reports of the organization or manuals. And these other aspects may remain unknown to those not participating in the process. And for this, we sought to develop an instrument that would allow us to seek the participating panelists or guideline group members' perspective, which we had published recently at the beginning of October, and it's called the Panel View Instrument. And I'll go over a few details of how we developed the instrument and what it will allow us to evaluate with guideline panel members. So internal evaluation of the guideline process would provide better insight into the process and specifically what occurred during the guideline development. And this may help guideline developers improve their methods and approaches that they use with the panels in future guidelines. And our objective for this research was to develop and validate an instrument to assess guideline panel members' perception of the appropriateness of the process and their satisfaction with the process of the guideline development. And here we used a multi-step development process for creating the panel view instrument that included item generation based on a systematic review, contacting guideline developers, and conducting key informant surveys of guideline panelists and guideline methodologists, item reduction step informed by expert consensus, and also key informant surveys and interviews, and key informant surveys to inform response phrasing, and finally, application of the tool and field testing with 8 guideline panels. So through this process, we developed the instrument that included, in its final version, 34 items that cover all aspects of the guideline development process, from administration, training, chairing of the panel, to writing the guideline and implementing and disseminating the guideline recommendations. And the 34 items in the survey instrument are phrased in a way to provide agreement or disagreement based on a 7-point Likert scale. And I'll show a few examples of the items. Here, in terms of administrative items, there's an evaluation of adequate time being given for guideline group members to complete their tasks. so to complete surveys or provide feedback. The panel chairs being able to manage the group process, again, an aspect I just mentioned in terms of rationale for this tool, to establish an atmosphere that ensured involvement of all panel members in the discussion and free expression of opinions, and appropriate management of potential interest of guideline group members, and in the evidence synthesis being free from bias. So again, this is from those from the perspective of those who participated in the guideline development process, whether they thought management of potential interest was done appropriately. A few other examples are given appropriate considerations to the evidence, including all relevant types. So the fact that a systematic review was conducted for a guideline doesn't necessarily mean it was used to inform the recommendation, and it was there was a direct link to the recommendation that the panel made when they had their discussion and consideration about their evidence when formulating a recommendation. The other two example items here are about giving appropriate considerations to patients' views, values, and preferences, whether that was done appropriately, and whether there was transparency in going from the panel's recommendations that they formulated in their meeting to those that appear in the guidelines. So a couple examples to show you. This is from the perspective of those participants and giving their view on whether the process was appropriate to highlight potential weaknesses, areas for improvement, as well as strengths of the process. And this allows us to identify these in a structured manner and highlight specific areas for improvement. And the panel view tool is intended to be used by organizations that are interested in evaluating new guideline programs or quality improvement of existing programs. And we provide a link to the panel view tool there. And for next steps of the research, we would like to use an administrative tool with additional diverse panels from various guideline organizations, as well as seek feedback on the use of the panel view instrument by guideline developers. And we have on our website contact form to contact us if you have a guideline panel that you're working with and would be interested in administering the panel view instrument to evaluate the process. This is currently available, and we would look for any opportunities that you might have with your guideline panels to use the tool. And here I'll just conclude. So methods and transparency in guideline development have advanced over the past 3 decades with availability of these new approaches, tools, and frameworks. And these innovations have brought in an era for development of rapid and living guidelines to address current needs. The frameworks and approaches also provide a method for formulating recommendations when evidence is considered insufficient or very low quality. And despite the format of a guideline, its methods and processes need to be evaluated to ensure rigor and trustworthiness of recommendations. And for this, we developed the panel view instrument to address the critical area in guideline development to obtain panelists' perspectives when they participate in guidelines. And I'll wrap up there. We have just a few minutes for any questions, comments, and discussion. Great, thanks for the questions. So should we use both panel view and the AGREE tools to assess methodology, quality, and development process? Yes, the two tools are, the panel view tool is not meant to replace the AGREE tool in terms of evaluating guideline credibility. AGREE tool is a validated tool to assess specific aspects of the guideline development steps as they are reported and that they are met in the reporting. Whereas the panel view tool is meant as an internal evaluation. So the AGREE tool would typically be used by a third party, let's say someone reading the guideline or an organization wanting to endorse the guideline. It wouldn't be a self-evaluation of the guideline. And the panel view tool is meant to be administered with your panel. So the AGREE tool won't capture some of the process issues that would be relevant to a guideline developer. For example, whether there was appropriate conduct by the panel members, whether anyone was speaking out of turn, whether the chair was able to manage that process. Those are aspects that aren't typically covered in a guideline report and addressed by the AGREE tool as a credibility assessment tool. Whereas in the panel view tool, we do capture those specific aspects of the process. And that way we're able to get an evaluation from the participating panel members, an internal evaluation, and get their views about the appropriateness of the process and their satisfaction with the process that they participated in. So they're meant to be complementary and not to replace one another in terms of the use of the tool.
If any of the participants wanted to become, like, you know, to see the process and to become part of a process of developing a guideline, what could they do to do that?
So in terms of being involved in the guidelines, so a couple aspects. So maybe from the organizational side, for example, in the ASH guidelines, the VT guidelines, the first example I presented, ASH involved guideline panel members, guideline observers as part of the process from their ASH membership. So, for example, people who may have been recruited to chair guidelines in the future. So they had this aspect of including observers, and that may be possible with guideline groups that you may be involved in or work with. For example, even if you're a member of the systematic review team, there may be an opportunity to sit in on panel meetings. This is something we've also started doing, is having the systematic review team sit in on the full process, even though they're not voting panel members, they don't formulate recommendations. They're able to observe the process. That's one method. The other method, not in the interest of self-promotion, but here at McMaster, together in collaboration with and partnership with the Guidelines International Network, there is the InGuide program that was developed as a training and credentialing program for training of panel member participants, as well as guideline methodologists and panel chairs that seeks to train and educate participants through the whole steps of the process. So that would be one other way of getting involved and learning more about the process itself, is through a training course such as InGuide.
Yeah, great.
Yeah, so this is a very good point. So the question is about, given that medical conditions typically don't vary worldwide, risk factors may vary worldwide, but the effectiveness of interventions, so for example, the use of an anticoagulant in Canada or USA versus the effectiveness of using an anticoagulant in Europe should not differ. We would expect to see similar relative estimates of effects. Should there be only one high-quality guidelines, regardless of which country they are used, they should be mostly the same. So there will be different guidelines produced, especially we've seen it also in the COVID-19 pandemic, that there are multiple organizations working on guidelines, sometimes addressing the same or related similar questions. And that's one aspect of that is reproducibility, but also there is an aspect of some duplication of research efforts. So groups should decide whether they may be able to already adopt and adapt an existing high-quality guideline that meets their needs. So, for example, if you have a panel or stakeholders that prioritize specific questions, and you do a scoping search of existing guidelines, you see those are already addressed, you may want to use that guideline. But what there may be different between countries are those contextual factors. So the clinical effects and effects on health outcomes may not differ for interventions, but other aspects that bear on the recommendation will likely vary. Cost being one big issue, feasibility, availability of the intervention being another issue, and those are the additional criteria that we have in the GRADE evidence decision framework. So maybe that we use the existing guideline that's evaluated as being a high-quality guideline, having high-quality systematic review and evidence synthesis supporting it as a starting point, and we may adapt the recommendation based on the different local contextual factors. So should there be only one? It may not be possible in terms of, or may not be possible in terms of the specific questions that are raised within a guideline. Different guideline groups may focus on the same clinical condition, but slightly different questions. But there is definitely an opportunity to adopt and adapt guideline recommendations if you have the same questions, but want to consider your specific local contextual factors and country setting factors, using, for example, the adultment approach that I mentioned earlier.
I'd really like to thank you for giving us a really important and I think like very interesting and recent, topic that's going on now in guideline. What new processes are happening in guidelines. I think you guys are on the cutting edge. So thank you so much for talking with us today.
Thanks so much for having me. It was a pleasure to participate.